they asked me to talk about blood thinners, and being an interventional cardiologist, we've got a bit of an interest in blood thinners, but specifically this, I'm going to concentrate this talk on what to do when you have patients who have a coronary intervention who need to be on an oral anticoagulant as well. Some of these things you know, but I thought it would be helpful to put up some definitions here. PCI, a stent is what we usually refer to there. Dual antiplatelet therapy means aspirin plus a P2Y12 inhibitor, and the common ones we use these days are clopidogrel and ticagrelor, less commonly prasugrel, and oral anticoagulants, warfarin. The newer oral anticoagulants are things like dabigatran, rivaroxaban, and apixaban. Beeper. Again, you guys know this. The coronary syndromes come in various forms: stable syndromes, which tend to cause exertional symptoms, and unstable coronary syndromes, ranging from unstable angina through to various forms of myocardial infarct. And we offer PCI and stenting to these patients to, number one, help their symptoms, improve symptoms of angina, but particularly in acute coronary syndrome, there's a large prognostic benefit to early angiography, revascularization, and particularly to appropriate medical therapy as well. We're very lucky with our current generation of drug-eluting stents that they're very forgiving when it comes to duration of dual antiplatelets. You may recall in years gone by, the first generation of drug-eluting stents were heralded because they had lower rates of restenosis after being put into coronary lesions, but then a year or two down the track found that they had very high rates of something called stent thrombosis, which was where you get sudden clot formation inside that stent, and then the vessel occlusion. Often it presents with myocardial infarction or sudden death, and that was a phenomenon that was probably due to the stent technology. The early generation drug-eluting stents healed slowly. They were incompletely endothelialized, and that's probably what drove the tendency for stent thrombosis. Modern drug-eluting stents are very forgiving. They're low profile, they heal early. The current stents we use are all CE marked for 1 month of dual antiplatelet therapy, which means that the rate of stent thrombosis drops off dramatically after a month. So it's really great because it gives you options for shortening the patient's duration of antiplatelet therapy, and also for considering the impact of needing to be on an oral anticoagulant as well. The duration of antiplatelet therapy, so for PCI after stable coronary syndrome, we treat for 6 months, and for acute coronary syndrome, we treat for 12 months. And ACS is more important to us, I guess, because about 75% of patients who present to us in hospital present with acute coronary syndrome, and they're also the ones that are higher risk of recurrent events in future as well. So they're ones that it's really important to get your treatment right. More and more people that come to us in the cath lab have an indication for an oral anticoagulant, and by far and away the most common indication is atrial fibrillation, of course, or atrial flutter. Some patients have a metallic heart valve, they need to be on warfarin, and some people have structural heart disease like moderate or severe mitral stenosis. They have an LV thrombus or an aneurysm, they need to be on anticoagulation as well. And of course, if someone's got a thromboembolic disorder like a DVT or PE, they may need to be on oral anticoagulation as well. And they say that around 5% of patients who come to the cath lab need oral anticoagulation, and I guess that's more likely to increase in future because the prevalence of atrial fibrillation is going to go up as the population ages. And the problem with giving an oral anticoagulant after a coronary stent is that you've got your competing risks. You want to give more blood thinning in terms of antiplatelets and the oral anticoagulant, but that's going to cause bleeding. But then you're worried about thrombosis if you withhold the oral anticoagulant. For example, dual antiplatelet therapy offers no protection from stroke and atrial fibrillation. But then you're worried that if you don't give enough antiplatelets, that the patient might have a myocardial infarct or a stent thrombosis. There are various scores to assess patients' risks of bleeding. The has bled is a kind of easy score to quickly evaluate someone. It's one we use frequently. You don't need to memorise that, but it'll be on the slideshow there for you. So probably the first bit of data that gave us some guidance in this regard was the WOAS trial, and it was a small trial, and the average age was about 70. Only about or less than a third of patients had acute coronary syndrome, so they were mostly stable angina patients. But what it showed is that triple therapy. I'll shine it up this way. Oh, there we are. Oh, laser's too small. Top line is triple therapy, so warfarin, aspirin, clopidogrel. The bottom line is clopidogrel and warfarin, and the outcome is incidence of bleeding. So there's a substantial reduction in bleeding with dual therapy, clopidogrel, warfarin, compared to triple therapy. And the other interesting thing, again, the top line is triple therapy, the bottom line is double therapy or dual therapy. And what's interesting is that the triple therapy group also had a higher rate of thrombotic endpoints as well. So triple therapy was with warfarin, aspirin, clopidogrel was clearly worse. But this was a small trial, and it was only powered to detect a difference in bleeding. Wasn't really powered for thrombotic events or other cardiac outcomes, but it was a hypothesis-generating trial. There was another small trial, ISAR triple, came out shortly after WOAST, which suggested that patients who were treated for a period of 6 weeks of triple therapy after a coronary stent versus 6 months had no difference in their primary endpoints, and this was a composite endpoint of both ischemic and bleeding events with an average age of about 74, but it was only a small trial with a short follow-up. That came after trial. The next bit of data is from the RELY trial of dabigatran, and this is a bit of a messy graph, but essentially you see the colours there. The colours represent the different trial groups. The orangey colour up the top is patients who are just on warfarin, and the grey is patients who are on dabigatran 150, and the green is the patients who are on dabigatran 110. And each of the bars of those colours represent patients who are either on no antiplatelet, single antiplatelet, or dual antiplatelet, and clearly the dual, being on dual antiplatelets plus the anticoagulant added to bleeding risk across all those groups. So patients who on dabigatran 110 tended to have a slightly lower bleeding risk than patients who were on the 150. But just last year, this paper came out, and I think this has been a very, very helpful to guide our clinical practice, actually. This is the REDUAL trial, which was a randomized trial in a large number of patients with atrial fibrillation who underwent PCI. And patients were randomized to either triple therapy with aspirin, clopidogrel, and warfarin, or aspirin, ticagrelor, and warfarin, versus dual therapy with either clopidogrel or ticagrelor plus dabigatran. And there were two dabigatran subgroups. There was a 110 milligram and there was a 150 milligram. And I think one of the strengths here is that 50% of the population were acute coronary syndrome. So I think that's very relevant for our practice with a mean age of around 70. And what it showed is that compared to dual therapy with a P2Y12 inhibitor and dabigatran, warfarin triple therapy was clearly associated with more bleeding. The dabigatran 110 group had a slightly lower risk of bleeding compared to the dabigatran 150, but both of them were lower than patients who were on the warfarin-based regime. The other signal that was in there was that If you're on clopidogrel, ticagrelor and dabigatran 110, your thrombotic event rate, including MIs, was just slightly higher than if you're on dabigatran 150. The trial was underpowered for looking specifically at those outcomes. There were relatively small numbers in there, but there was some signal towards that. But I think it's helpful because, number one, it means that we've now got fairly robust data to support using dual therapy with a newer oral anticoagulant. I think 150 milligrams a dose of dabigatran plus clopidogrel or ticagrelor is safe and causes lower bleeding rates than warfarin-based triple therapy. But I don't necessarily think 110 is that much inferior. There are some patients, particularly elderly patients, who you really want to try and minimise their bleeding risk. And I think that using dabigatran 110 plus a period of clopidogrel or ticagrelor is perfectly valid, because you may be trading off a significant reduction in bleeding for a slight increase in risk of recurrent MI or thrombosis, and that may be an acceptable compromise in certain clinical situations where you're really concerned about bleeding as well. What else? So once you stop the antiplatelet agents, the optimal therapy, i.e. whether you should carry on aspirin in the long term, is not really known. But like I said, the current stents are really forgiving, and I don't think we're as scared of stopping dual antiplatelet therapy early if we need to. Most patients, so for example, after acute coronary syndromes, patients will have a year of antiplatelet therapy, and after that point, if there's no further concerns, then we'll often just discontinue the antiplatelet and leave them on long-term oral anticoagulants alone. There might be certain situations where we'd be worried about a recurrent event. For example, if someone had a complicating stenting procedure or had a suboptimal outcome from angiographic outcome from stenting, or if someone had a previous stent thrombosis, we may want them to continue on the antiplatelet or on an antiplatelet as well as the oral anticoagulant. But generally, you guys would be guided by us, and it would generally be either us as interventionists or the general cardiologist making that call. But definitely adding an antiplatelet onto long-term oral anticoagulants does increase the bleeding risk slightly. I tend to use proton pump inhibitors for most of my patients on dual and triple therapy, but particularly the elderly, I think it's almost mandatory. GI bleed is a very common complication for them. So now we get to the cases here, and first case was Bob, and he's on dabigatran for long-term AF, and he needs to be on dabigatran. His CHADS2 VAS score is 3, and he was admitted with acute coronary syndrome, and he had a couple of stents. He had a culprit lesion treated, and then he had a non-culprit and a slightly tricky lesion. It was a chronic occlusion, a little bit calcified, but successful angiographic outcome. So what do we do with his long-term anticoagulation? Well, he's presented with ACS, so he needs a year of antiplatelet therapy. But I would argue, based on we don't know how old Bob is, but if he fits within the ReDual trial and his age is around 70, then I would argue that we should treat him with dabigatran 150 milligrams BD and ticagrelor. And then after 1 year, if there's no further cardiovascular concern, I would discontinue the ticagrelor and just treat him with dabigatran alone. I guess they're getting here that one of the lesions was a little bit tricky, and there are some chronic occlusions, calcified lesions are prone to restenosis, but I'd have confidence that the operators treated that lesion properly and got a good angiographic result, and I don't think there's necessarily any need to continue long-term antiplatelets if he remains well and symptom-free after a year. A second case is Hong, who's a 55-year-old male who's got a St. Jude's metallic mitral prosthesis, which was done 10 years ago, and he's on warfarin, of course, and his INR's well controlled. And he presents with an acute coronary syndrome, which he's had treated. He had a short focal culprit stenosis in his coronary artery. He's had that treated with a single, presumably drug-eluting stent. So what do we do about his anticoagulation? And again, I think it's similar to the previous case. He needs a year of antiplatelet therapy, and I would argue for single antiplatelet and carry on the warfarin, and being really particular to try and keep the INR in the therapeutic range. An antiplatelet plus a sub-therapeutic INR is probably not going to be as safe as dual antiplatelet, so it's important for patients on warfarin to pay a little bit of extra attention to keep their INR in that therapeutic range. I would treat them with a single antiplatelet agent, and Woest would argue that we could use clopidogrel. I haven't presented any data which looks at that ticagrelor plus warfarin in this situation, but I think that the redual is somewhat reassuring that might be an option, though strictly speaking, we've only really got data to show clopidogrel plus warfarin. I would not use triple therapy in this man. I think that the bleeding risk is substantially more than dual therapy, and I don't think it offers necessarily any better cardiovascular outcome for him. There we go.
Cool. Thanks for that, Will. So that's a comprehensive coverage of what's a challenging topic, even when we're looking directly after the patients. I guess the key message is ask if it's not clear, which is what we do. There's a couple of questions. They're not so much targeted at anticoagulation, but certainly I'll be interested to hear your answer to this one. It's treating moderate to severe coronary disease and a patient's asymptomatic. Is there any benefit for preventative stents? Sorry to put you on the spot.
Yeah. So I guess the real question is, if someone has coronary stenoses but they are asymptomatic and well, what do you do? Number one, medical therapy. Aspirin, statin, antihypertensive, diabetic control. That's the most important thing. The second thing is to question, are they asymptomatic? And I think that you're obliged to do some form of functional testing, stress testing, for example, exercise stress test or stress echocardiogram, or sometimes we can do that in the lab as well. We do a test called fractional flow reserve measurement, where we measure each individual coronary lesion. If that patient is truly asymptomatic and there is no evidence of inducible ischemia, I should say one more thing, and it's not a left main stenosis, and it's not a proximal LAD stenosis, and their LV function is normal, then you leave them alone and you treat them medically. If they fall into any of those other criteria, then you can make an argument for revascularization. But I think the evidence is very clear. Even if someone has coronary stenosis, if they are asymptomatic and there is no objective evidence of coronary ischemia, then you treat them medically. That's my opinion anyway. Yeah.
Thanks for that.